department. So, of course, emergency departments around the globe are frenetic, busy, time-pressured places. And at UCH, we see about 350 patients a day in our emergency department, admit about 50 or 60 of those. Each one of those 350 patients are coming with their own individual problems. But thankfully for us, a lot of those problems can be brought down into themes, and those themes can allow us to develop protocols, care pathways, etc., that make care much more predictable, make it manageable, etc. Now, despite that, which is good, there's still a problem, is where it is safest to deliver that pathway. Is my patient safe enough for me to deliver that care at home? Or do I need to bring them into the hospital to keep an eye on them? Well, I'd suggest at the moment, most of us would say, if we were a bit worried about a patient, we'll say, well, the safest place to manage a patient, of course, is in the hospital, where I can keep an eye on them, and if something should happen, well, I could do something about it. And that's fair enough. Now, if we go and have a look at one of the sort of commonest themes and some of the patients that present to that theme, we can see where this might take us. So the commonest theme, perhaps, is complex infection. And we can see from the list up here, there's a great range of possibilities that can happen. We could have a young lady who's perhaps got a urinary tract infection that's gone up to her kidney. Maybe we've got a chap with diabetes and a skin infection, or someone who's got a worsening of his inflammatory bowel disease, maybe even someone more complex than that. They've had chemotherapy that's knocked out their immune system, and now they've come in with a temperature. So very different cases, but the theme of complex infection remains the same. And this is sort of good in a way as we start to go on and analyze the risk of managing these patients, because generally they're all very discrete illnesses. The bugs that are causing the problem are generally pretty predictable. And usually these patients improve very quickly indeed once we start the correct therapy. And in most hospitals, there are now defined pathways and protocols of how to deal with that. But, of course, maybe I'm looking at this patient and saying, well, you know what? Maybe I'll need to do an extra ultrasound or CT scan, and so perhaps I ought to bring them into the hospital. Oh, maybe I'm going to have to ask our microbiologist a question, so I'll bring them into hospital. But the reality is I can get those ultrasounds done at the front door. I can get the CT scan done at the front door. The microbiologist rarely needs to see the patient. I can pick up the phone and talk to them. But, of course, the real killer in this bit is I don't have a crystal ball. I don't know what's going to happen to my patient when I send them home. Are they going to get worse? Are they going to come back in the middle of the night dead, like the patient we just saw? Well, I can't be having that, so I'm going to bring them into hospital, I'm going to sit them in the bed, and I'm going to watch them for a few days. Hopefully they'll get better, and then I'll send them on home. But of course, that's taking up an awful lot of time, an awful lot of space, an awful lot of money, and really, does the patient really want to sit in a hospital bed? And I wonder if Nightingale could come up with a solution to deal with this. I call it simple. Of course, actually, it's highly complex from your angle, but from our angle, it does need to be brutally simple and easy to use. But a solution, a system that can assure us that we can be able to accurately identify any deterioration. A system that puts the patient at the heart of everything, that allows communication two ways. A system that builds in its risk management, but is dynamic, that it updates as the patient's treatment goes on and condition changes, hopefully of course for the better, that the risk analysis changes with that. And of course, if things aren't going the way that we want it to, a system that can reliably and safely trigger a readmission of that patient to hospital. If we could develop that sort of system, then perhaps that initial statement would change. In fact, maybe the safest place now to look after my patient is not at hospital, but at the hospital at home. And if we can do that, we can change many things. We can free up the beds for patients that really do need to be there. Now, of course, that could work for a number of patients, and that's grand. But of course, not everyone should go home. There are sick patients that need to come in. And here, perhaps, is an example that, again, reflects on the things that Cor was saying earlier and John has only just iterated. Here's a chap He's only 45 years old. He's got a really nasty condition called pancreatitis. It's inflammation of the pancreas gland. It's a really nasty thing. It's often kicked off by gallstones. Now, he's brought into our emergency department and is moved to our acute medical unit at 8 o'clock in the morning. The handover from the medical team says he's fine. Well, great. Now, we could imagine a Nightingale system starting to get to work now, starting to get to learn the patient, starting to do a bit of risk analysis here. Maybe he is fine, and that's great. A junior doctor is now asked to look after this patient on the ward. But he's now complaining of really nasty pain. Now, this is noted in the notes, but it doesn't really go anywhere, that information. And again, perhaps a Nightingale system which allows a patient to interact with it could start to feed those soft signs that John was talking into the risk analysis. Things aren't going great, and by 11 o'clock that morning, he's breathing faster and his heart rate's thumping away. It's charted beautifully on our paper charts, but we don't seem to do too much about it. Again, we could imagine a Nightingale system equally being able to pick those signs up, chart them electronically, but then start to readjust the risk analysis here, and if the risk is beginning to move in the wrong direction, to alert perhaps more senior members of that medical team. By lunchtime he's in agony. And again, it's beautifully noted, but it doesn't really go anywhere. And again, a system that allows the patient to interact could feed that information in. Blood tests from the morning are starting to come back. Shows his kidneys and liver in a really pretty bad way. But the junior doctor looks at them and goes, "Oh yes," files them. Our Nightingale system clearly would be alerting that to, again, other members of more competent staff. Unfortunately, by 5 o'clock, things are beginning to look really not very good at all. His blood pressure's falling, he's cold, he's clammy, he's shocked. And again, we could be picking that up instantly with electronic monitoring, readjusting our risk analysis, which clearly wouldn't be looking very good by now, and that message would now be going out well beyond the medical team, perhaps to John's emergency team, or maybe Core as the anaesthetist. The junior doctor's seeking help. She realizes she's got problems now, but the team are busy and no one comes. At 7:30, they come round to look at the patient, but he's not there. All the patients in that bay say, "Oh, he got up sort of quarter of an hour ago, he's just gone to the toilet." So we go and knock on the toilet door, but of course, no answer. Break down the door, and there he is, dead on the floor. Again, an accelerometer would have picked up the fall. The pulse rate would have gone to 0, the respiratory rate would have gone to 0, and the call wouldn't have just gone to John, but would have gone to Core's cardiac arrest team. But none of that happened. Like Core said, he died unnoticed in a toilet in one of the most advanced hospitals in the world. Our hospital is probably one of the best run hospitals within the UK. But in the last few months, because we were admitting people just to watch them and monitor them with complex infections who could have been done at home, we had to cancel surgery. We lost about £2 million in the last few months for that reason alone. And this is not a story at UCH or Utrecht. This is a story that plays out across Europe, across the US, every hospital, every day. And my guess is, for you guys sitting here, each one of you have got an idea of how you could have saved that poor patient. And each one of you has probably got a reasonable idea how you could prevent admissions, keep the surgery rolling, and keep the hospital open for business. And that's why I'm so glad that you're all here, and thank you very much indeed. So together and with Nightingale, hopefully we have that opportunity to make the difference. So thank you very much indeed, and look forward to it.
Thank you, David. Thank you, John. I hope that illustrates why we're here. And again, these are two examples from London, but I think both Cor and I can vouch for the fact that stories like this, how sad they happen in every hospital everywhere on the world today. And we're here to try to amend that. We'll see if we get there.